We've clearly come a long way in the treatment of lymphoid malignancies, ALL, myeloma, CLL. There's been an explosion of therapies across the board. But really the principle is we need better tools, or we have to use our best tools to monitor response. And there's definitely a link and a connection between our therapies and our MRD, or minimal residual disease testing. We have our historic tests of changes in blood counts, bone marrow studies, looking at morphologic remission, classic genetic tests like cytogenetics, classic additional cytogenetic testing like fluorescence in situ hybridization, or FISH. And these have been workhorses for decades, but clearly as we try to make decisions about what is the best path for a patient with a higher grade lymphoid malignancy, or even a lower grade lymphoid malignancy, MRD testing has become the king. There are multiple different techniques we can use, but what we're looking to do is to judge whether patients had, in many cases, a very early and rapid response to therapy, which predicts for certain paths in many treatment plans. This has been pioneered in pediatrics, and I think it's the case in adults. We want to understand the effect of therapy to get patients to a deep enough remission to consider whether transplantation, that is allogeneic stem cell transplantation, is the right choice or not. And this holds true for both myeloid and lymphoid malignancies. So, and lastly, of course, monitoring a patient who has been treated to track any early evidence of relapse, I think, is also another scenario where MRD testing has become important. So it's become ingrained in the culture of treating a higher grade and even a lower grade lymphoid malignancy patient than MRD testing shows you how well you've done, what the next step might be, and when it's time potentially to think about an alternate step or return to therapy. As we dig deeper in lymphoid malignancies, we clearly have better tools available. And I mentioned that cytogenetics and FISH have been workhorses for decades. Flow cytometry is probably the next thing to discuss. And that really has always been and has become increasingly important to detect MRD with as good a detail as we can. I think we can clearly look at cellular subsets much more carefully than we used to with more complex flow cytometry that's available. That being said, I think we've learned a lot about the molecular underpinnings of ALL, and I think that's become perhaps even more important. Some areas to highlight would be the fact that some cases of ALL really behave like other molecularly driven diseases where there's a molecular target. The quote-unquote Philadelphia chromosome-like ALL is one example. And that's a case where MRD testing may be driven by molecular parameters, where we look for PCR, standard PCR, or newer techniques I'll mention in a moment, to follow a molecular driver. Molecular testing across the board has become important to look at what is the biologic, but more of a molecular underpinnings of a disease. How complex is it? What's driving it? It may not be something that is trackable and shows disease response, but it will point us towards therapy choices, help us assess risk and behavior of leukemia. So next generation sequencing is a platform where we can look at very low levels of molecular markers that we either expect or may not expect as the disease is first diagnosed or treated and may evolve. There are other techniques to look at very small levels and very minute changes, single base pair changes, techniques such as allele-specific oligonucleotide PCR, which again can look at a single nucleotide change in a single strand of DNA. So all these tools, I think, again, are available to help us, first and foremost, choose treatment, understand response, track a patient into deep remission, and to make decisions about their proper path, but also to help us understand the disease better, to expand our treatment choices into the realm of targeted therapy, and help us really better cure these diseases.